Hello everybody, welcome. Today we're going to be exploring the topic of the spectrum of epilepsy. My name is Natalie Hennessy and I'm the Clinical Director with Able Care Therapeutic Services. We'll try to get to as many questions as we can during the webinar or as follow-up. So I'd like to advise that the information provided today in the webinar is general information only, so that does not take into account your own particular work situation or your objectives and needs. So before acting on any information contained in the discussion, you should consider the appropriateness of the information with regard to your own objectives, work, financial situations or needs. So now to kick things off, I'd like to do a quick poll of participants. So what we wanted to ask you was, how confident are you in your knowledge about epilepsy? So just go ahead and tick one of those buttons now. And then we'll see where we're at. That's great. So we're about to start the discussion on the spectrum of epilepsy. So we'll start by talking about what seizures are and what epilepsy is. Seizures are categorized by the areas of the brain involved and then the symptoms that occur as a result of uncontrolled overactivity in those areas. A seizure might involve the entire brain, and it might be then called a generalized seizure. When a seizure only involves part of the brain, it's called a focal or a partial seizure. So a seizure can also start as a partial seizure involving only part and progress to a generalized seizure, which then affects the whole of the brain. So let's go through the two types of generalized seizures. You have tonic-clonic, which is also sometimes known as grand mal, and that's when somebody will be very rigid, they'll be jerking, shallow breathing, possible loss of bladder and bowel function, and usually it can last up to a few minutes. Afterwards, they may be confused and fatigued, and then that's followed by a return to full consciousness. If you have a look at an absence, that is also part of a generalized seizure and called a petit mal. And that's where it might present as a blank stare that begins and ends abruptly, maybe lasting a few seconds, and the person won't be aware of that it has occurred. Sometimes you'll have rapid blinking or some other strange movements. Then if we have a look at partial or focal seizures, you have a category called a simple partial. So that's when the person's awake and aware and there'll be uncontrolled jerking, and it will begin in one part of the body and then possibly spread around. The person who's having that seizure will feel that the environment is quite distorted and have some perceptual changes. They might see or hear things or feel some very strong emotions and feel nausea. Sometimes a simple partial seizure can also present as a person becoming suddenly aggressive or angry, but that's not all the time. A myoclonic seizure is when you have a sudden, brief, massive muscle jerk, and that can involve the whole body or parts of the whole body. It might cause the person to sort of spill what they're holding or fall or drop. And then you have a complex partial, which involves the temporal lobe. And that usually starts with a blank stare, some other random activity or movement. They might appear dazed or clumsy, unaware, unresponsive. They can run around, struggle or flail, and that's what it can have a range of different presentations. Another form of seizure that you have is called Statusepilepticus, and that is a term generally used to describe a seizure or a number of seizures that have occurred in quick succession. So there's no recovery that's happening between the seizures, and it can last sometimes it can last up to around 30 minutes. If it's left uncontrolled, it can cause permanent brain damage and in very rare cases death, but it is an emergency situation. The most common medications that are used for somebody who's having a seizure are preventative, but there are also medications that will be prescribed in the situation when somebody does have status epilepticus. It's important to know that it's not always a fit as such where people are having a myoclonic tonic-clonic phase. It can be somebody who is just sitting there and appearing absent for a long time. That depends on how the seizure presents itself. Very important to remember, though, that regardless of the presentation, that it is an emergency. So let's move on to have a look at what the first aid response should be and recommendations for somebody who is having an epileptic seizure. In the handouts for the for here, which we can, I'll just give you one of those ones. So there's two handouts for the webinar. One's categories of seizures and one's first aid epilepsy, which is what we'll just have a look at. This is recommendations from Epilepsy Queensland and the Epilepsy Centres of South Australia and St John Ambulance. So for somebody who's having a seizure, a major generalised seizure, again, it's important to note the time of onset of that seizure. Calling an ambulance if you think there's an injury or they're having breathing difficulty or there's no history of seizures for that person. The same principles that you would have for first aid are there, protecting them from injury, not trying to restrict any movement, removing any objects that will cause them harm, and not putting anything into their mouth during the seizure. So if you're looking through those, it's monitoring their airway to ensure that they can breathe and gently rolling onto their side in terms of a recovery position as soon as possible. If they are in a wheelchair, you leave them in the wheelchair as long as you can maintain a clear airway. So I'll leave those handouts for you to have a look at and go through. This one gives some information around giving intranasal midazolam, which we'll look at further on in the webinar, depending on whether that's been prescribed for the person that you're supporting. So let's have a look at the recovery position and just refresh what that actually looks like. So you see this gentleman here is demonstrating how you would roll somebody into the recovery position. And onto their side, managing their jaw and their airway. And then going to seek further assistance. So one of the areas or the ways that people are supported who have epilepsy will be there'll be a range of medications. One of them is often referred to as intranasal midazolam or buccal midazolam. So there's a number of medications from pharmaceutical companies that are available for epilepsy. The particular brand may vary, and you should always refer to any patient educational material that the pharmacy or your neurologist has provided. Well, I want to have a look at some of these little videos here, which discusses the use of that emergency medication type and give you some examples around so you can actually see some people using them.
Intranasal atomizer device I wrote about in the column this month. Hi from iPads if you're using the iPad app. Just a quick disclaimer, this is the LMA intranasal device. I have no conflicts of interest. I don't particularly support the LMA atomizer device over any other atomizer device. This is just me speaking, not my employer or anything like that. So I think these things are great for a lot of things, for pain control, for seizures, for narcotic overdose. So it's just it's a little lure lock here. You just hook it up onto any syringe, lure locks on tightly. You put your favorite medicine in here. This is a 3 ml syringe, which is good because you don't want to give more than a milliliter in each nostril, as I'll show you in just a second. And you just go in like that, and it's a one-time use. You throw it away. It's a great tool. Thanks so much. So here's just an example of the atomizer, so you can see it. Everything kind of comes out in a fine mist. Okay, so I'm going to demonstrate how to use the device. So I've hooked up to a 3 ml syringe. Like I said in the article, you should really probably only use a maximum of 1 ml per nostril, because otherwise it'll overflow. We've got 3 3 here, so I'll do 1 in one nostril, and then I'll show you that 1.5 is probably a little too much. So here we go. Ready? You just kind of obstruct the nostril like this, and you have the patient inhale as they're doing it. So, and there's a little bit of salt water, and that's not even a milliliter, and it did feel like a lot here. So I'm just going to inject here now. And that was a milliliter and a half, and it definitely went down my throat anyway. So a milliliter probably should be your maximum. You could obviously redose it a little bit later, but I'd probably recommend just a milliliter. Thank you so much.
What I like about that little video is that it just makes it really quite simple and not too scary, I guess, for a lot of direct support workers when we're talking about using an intranasal medication device. So here's another little short video which has been developed to assist people who will be supporting this administration of medication.
How to give your child midazolam. Midazolam, also known as Versed, is a medicine that is used to treat prolonged seizures or clusters of seizures. It is sprayed into the nose using a syringe and atomizer. Your provider has prescribed a nasal midazolam kit for your child that you will use if they have a prolonged seizure or numerous seizures in a short period of time. Make sure you contact your provider for more specific recommendations. Your kit should have either a pre-filled syringe and atomizer, or you may be given a vial kit with syringe, needle, or needleless vial adapter, an atomizer tip, and a bottle of medicine. Some pharmacies may dispense a pre-filled syringe in 5 or 10 milligram doses. If your child's dose is not 5 or 10 milligrams, you will have to use the kit to draw up or waste a specific amount. Ask your provider or nurse to show you where to draw a permanent line on the syringe that shows you the total amount of medication to give your child. That way you won't make a mistake when you are scared or nervous. Keep the kit together and store it in a secure place so that it will be easy to give your child the medicine when they need it. We suggest you keep it with a timer so that you can time the seizure or seizure cluster. When you bring the kit home, it is okay to practice using water so that you become comfortable with it. Please do not practice on your child. Practice as many times as you need to so you know all the steps by memory. To give your child midazolam through their nose, first, pop the plastic cap off the bottle of midazolam. Connect the needle or adapter to the syringe by twisting or slipping. Poke the syringe into the medicine bottle. Once the vial is punctured or the pre-filled syringe is opened, the midazolam should be discarded within 28 days. Please write down the 28-day expiration date on the punctured vial or opened pre-filled syringe. Tip the bottle upside down so the syringe is on the bottom and the bottle seals face down. Pull the plunger down until it reaches the mark your provider or nurse put on the syringe and let the syringe fill with the medication. Disconnect the syringe from the needle or adapter by twisting it. Attach the atomizer tip to the syringe by twisting it, making sure to firmly lock it into place. Use your free hand to hold the child's head still. Place the tip of the atomizer tightly against your child's nostril, aiming slightly up and outward towards the top of their ear. Quickly push the plunger up to deliver half of the medication into one of your child's nostrils. Move the syringe over to your child's other nostril and push the rest of the medication in. The more often you practice these steps with water, the easier it will become, and you'll feel confident and calm if you ever need to give your child the medication. There are practice kits available for purchase at some pharmacies if you would like to practice administration at home. Nasal midazolam should stop the seizure within 2 to 3 minutes. If it does not stop, you should consider calling 911. Your provider's office may or may not recommend you call 911. please ask your provider about this recommendation.
So that's a lovely little example. It is American, so we don't call 911. It would be 000 or 112 for if you're on mobile. But there's a number of resources that are available on the internet that are developed by epilepsy associations or the pharmacy that might be prescribing or providing, the medication that your child or the adult that you're supporting has. So it's important to have a look at those as well. So let's go and have a look now. We're going to turn to looking at plans and prevention. So it's really important that if somebody has a seizure or epilepsy, that they have a care plan. And a seizure care plan needs to cover a number of different areas, and it should be signed by the doctor or the neurologist that is providing the primary health care for that person. The elements of this is an example of a seizure care plan to use. So it looks at the seizure types and it provides a description of what the type of seizure actually is. So if you're looking at the seizure type, you might have that tonic-clonic, an absence, or simple partial. So in this particular form, it's giving some more depth and description about what that person's seizure actually looks like. So tonic-clonic might be, for example, they might be not responsive, they might fall down, they might become red or blue in the face, their tongue might be bitten, might be lasting, up to 3 minutes, and confusion, and then possibly a deep sleep, maybe hours when they're in recovery phase. An absence might be a vacant stare lasting 5 to 10 seconds or impaired awareness. Again, simple partial, which we touched on before, discusses that might be some jerking. There's often rapid recovery from a simple partial seizure, and they might experience change of sensations. For example, they might say that they're seeing sounds or flashing lights or having strange tastes or smell that they're feeling. Going on from this particular seizure care plan also describes a complex partial and what that might look like. There'll be a section that talks about recovery management. So that's signs that the seizure is starting to settle. So how do you know that that person is coming out of that seizure? Duration, how long does your recovery usually take afterwards? You might find that they sleep for a number of hours or they recover very quickly. The person's reaction is also important. Often somebody who comes out of a seizure might be confused, and then that can result in them perhaps being a little bit aggressive or confused, and it's really important that people understand how to support somebody in recovery. Any additional information that should be in that care plan, and that might be who's the pharmacist to contact, if there's an additional seizure management plan or hospital plan that needs to be followed, and any additional seizure logs or observations that need to occur following the seizure. Really important that it's shared across all care providers and that you have authorization from the treating general practitioner and or neurologist. The other part of supporting or providing support to a person that has epilepsy is to ensure that you keep records of the seizures that they do have. So a seizure observation log is often part of a seizure care plan. So this information is recorded so that when there is a review at the doctors, that they can have some really clear factual information about whether the medication is helping to control the seizures or it's not. So maintaining these accurately is really, really important for developing any recovery management or recovery plan. So there's an example here. So it's a seizure observation log. Again, you write the date, the time, the length of the seizure in seconds or minutes, the seizure observations. So what did you actually observe? Was it staring? Whether they're unresponsive? This particular form uses a coding down the bottom, but sometimes people will just describe it. So seizure observations, what type of seizure was it? Recovery observations, how long did they take to recover? Were they continent or incontinent? Any other generalized comments, and ensuring that it is signed. So it is really important if you are supporting a person that has epilepsy that if you are required to maintain a seizure observation log that you do that. So let's talk about then some of the triggers, or how do you support somebody to stay healthy? There's a number of things that we do know through research that can cause increases in seizures. If a person becomes very anxious, that can trigger an epileptic fit or a seizures. Being tired, staying up too late, doing too much work can also be a triggering factor. Playing too much PlayStation or computer games with flashing lights and things like that can also, for some people, be a trigger. Strobe lighting, flashing lighting, those kind of things sometimes can also be triggers for people with epilepsy. Drinking too much alcohol or using other illegal substances can also affect how much somebody has a seizure or the severity of their seizures. And generally being stressed can also be a triggering factor for a person that might have epilepsy. So if we want to really help the people that we support with epilepsy to live full lives, it's obviously really, really important that we support them to live in a way that will allow them to achieve those particular goals. So working through your care management plan with that person and being aware of the issues that they might have relating to staying healthy. So we'll probably end here. Thank you for everybody for your questions through the webinar. And we will be following it on with another series which goes into a little bit more depth around how you can actually support somebody with epilepsy depending on the category of seizures. Now before we end, I'd like to just do one more little snap poll. So after the discussion, how well do you feel that this has changed your understanding of epilepsy? So if we can just... Everyone could have a little vote on that now. That's great. Well, so the poll results are in, and it looks like that everybody did feel that they have increased their knowledge of epilepsy. Just before we finish, I'd like to just remind you, if you do have any other feedback on the topic or webinar, we'd be really happy to hear that. And if you'd like to revisit the webinar, an archive will shortly be published, which you can review at your leisure, and that link will be included in our follow-up email correspondence. So, in finishing, there is a little bit of information about our next upcoming seminar. We'll be having, next month's topic is child protection and child protection skill set, and I'll be presenting that with a number of other guest speakers from the Able Care Therapeutic Services. So it's goodbye for now, and best of luck with all your work, and thanks for joining us in our webinar today.